thank you for allowing me to come and talk to the group. I think this is the maybe third or fourth time that I've had the opportunity to come and talk to the PF warriors, and every time I do, it's just absolutely thrilling and wonderful, because coming and seeing all of you and all of the caregivers and all of the love and compassion that's in the room really invigorates me and really pushes me to be a better doctor, to be a better researcher, and to as the cure IPF. That's the goal, right? So that's truly what we're working on here. I think another aspect of my job, though, is to educate. So as Joe mentioned, my job is not only to educate, some of the residents and the medical students, but also to educate my patients and my patients' caregivers. And so that's kind of the way that I look at these types of opportunities, is where I actually get to spend time talking with you and just educating you. I try to do that when I'm seeing patients in the clinic. Sometimes it's a little bit difficult to do that to a large group of people. So this, like I said, this type of opportunity really is it's something I treasure. I actually love doing this. So I'm glad that Shelley and Bill have asked me to come back a few times to talk about topics that I'm passionate about. So with that as kind of the backdrop, I'll go ahead and see if I can share my screen here, and we'll get started. We'll get started talking. So can everyone see? See the slides here, I hope. Okay, so today I'm going to talk about pulmonary fibrosis, or the genetics of pulmonary fibrosis. So
first of all, I don't have any disclosures. I'll talk a little bit about some off-label therapies. So really the objective today is to just provide kind of a framework or a foundation of knowledge regarding whatever genetics is supposed to mean, and what physicians are talking about when we talk about genetics and the genetics of pulmonary fibrosis. I'll talk about these genetic concepts kind of within the framework of pulmonary fibrosis, and kind of start talking a little bit about how we think that genetic variation impacts or influences the clinical course of a patient that has pulmonary fibrosis. I'll spend the last few minutes actually talking about genetic testing and ways that we can actually look for specific genetic variation in patients that we're seeing in clinic. So the first concept of genetics really boils down to this slide. So this is one of the basic tenets of biology, is that you have a human here. Humans are made up of several trillion cells. That's trillion with a T cells. All of these cells kind of look similar to this, where they have kind of this weird looking outline, and in the center they have something called a nucleus. And the nucleus really is the storage space for all of our chromosomes. So humans have 23 chromosomes. The chromosome basically looks like an X. That chromosome is made up of tightly packed DNA. In fact, it's very tightly packed. So if you take DNA from an individual cell and stretch it out end on end, it makes up a couple of feet. So you have a couple of feet of DNA in a string that's packed within the nucleus of the cell that is microscopic. So it's just a wonderful feat to actually realize that you have so much DNA in one individual cell. I read a fun fact the other day. If you take all of the DNA in our body, so if you take the DNA from the trillion cells in our body and stretch them end on end, you can go from the earth to the sun and back a couple of hundred times. So that's how much DNA and how much molecules are actually packed into these tightly wound chromosomes and then packed within this nucleus within the cell within our body. So it's actually a quite marvelous feat. DNA is really just a string of letters. So there are 4 letters that are in DNA. So there's T, A, C, and G. There are 2 strings of DNA. So one string of letters is bound to another string of letters. And like I said, that string stretches out several feet. These letters actually just make up a recipe. Okay, so the recipes are are found within what we call genes. So within the DNA, there are segments of DNA that form what we call genes. A gene is essentially just a piece of DNA that forms a recipe for proteins. And so each one of these genes makes up one individual and unique protein. So here, gene 1 forms protein 1, or forms the recipe to make protein 1. Gene 2 makes the recipe for protein 2, and go on down the line. So in humans, we have about 20,000 genes. Each one of these genes, again, is unique and makes up and forms a unique protein. So a variant is really just a change in the letter of the DNA. So here it was a T, so we changed the T to an A, which is a variation or a variant. Some people will call these mutations, but I call them variants. Okay, so this is a variant. It means that there's a different letter there than what should be there. Depending on the location of that variant and the type of that variant, it may impact the recipe for the protein. In fact, it may end up causing this protein to not be formed at all, or the protein may be formed but not function the way that it's supposed to function. And proteins are actually what actually carries out all of the functions of the cell. And so if you have an abnormal protein, or a protein that either is not formed or does not function, it could end up causing a problem with the cell, and then end up causing a problem with the organ itself, excuse me, and then cause a problem with the body, or cause a disease. Okay, so genetic variants may be harmful or harmless. So this is an example. This is a couple of NBA players from back in the 90s. This is the tall person, there's Manute Bol, and the short person's Muggsy Bogues. And so you can tell that they're quite different. One, Manute Bol, I think, was 7'6", and Muggsy Bogues was 5'4". And so their difference in height really is a harmless function of genetic variation. Okay, so our height. Another harmless, genetic variation would be eye color or hair color. And so there are some of these genetic variants that, although they're different when you look across individuals, they're not actually causing a problem. On the other hand, you can have some genetic variants or mutations that cause diseases. So these are foundations of people that are of diseases that are formed by genetic variation. So you have sickle cell disease, Huntington's disease, cystic fibrosis, muscular dystrophy, and then a disease called HHT, which are all genetic diseases that arise because there's a problem with the DNA, or there's a variant in the DNA. Now, there are several types of variants, but in the world of pulmonary fibrosis, we can break them down into what we call common variants and rare variants. So this represents about 100 people. Okay, so I tried to make about 100 people here. And all of the green people have what we call a variant in their DNA that's a common variant. So by definition, common variants occur in over 5% of the population. So if you go to the grocery store and there's 100 people in the grocery store, you can identify common variants in greater than 5% of those people in the grocery store. So if we're looking at a disease like pulmonary fibrosis, we know that pulmonary fibrosis does not occur in 5% of the world's population. It occurs much less. So these common variants are common in the population, yet they don't always cause disease by themselves. On the other hand, rare variants are extremely rare. So they're aptly named. Rare variants, by definition, occur in less than 0.01% of the population. And many of the rare variants associated with pulmonary fibrosis actually occur in much less rare than that, or even ultra rare. And some variants are only found in individuals or in one family in the entire world. So these are extremely rare variants. So if you went to the grocery store and there was 100 people in there, none of them would have one of these rare variants. The variant frequency, or the how common a variant is, actually gives us some information on whether it's causing a problem or not causing a problem. So if you have a common variant here that is, again, common, it's present in over 5% of the population, then its effect on causing disease is generally smaller. Meaning if you had 100 people and 5% of them had disease, 5% of them had a variant, only one may actually have disease. So this influence of this variant on the presence of disease is relatively small. On the other hand, if you have a rare variant, meaning there's only 1 in 1,000 people that have this type of variant, but yet that one person ends up developing a disease, related to that variant, the effect size is actually quite large because you have variant equals disease. So rare variants confer a larger risk of developing a problem, whereas common variants confer a smaller risk. In humans, there's been actually a lot of genetic studies looking at how many people have these variants and how many variants are there. And so like I said earlier, there's about 20,000 genes in humans. And any one individual will have one of these variants in about 100 of their genes, yet they don't necessarily have a disease or have a problem. And so there's still a lot about the genetics, human genetics, that we're still trying to decipher. But in general, extremely rare variants that are associated with disease are uncommon in the general population. So how in the world do we end up getting these variants? Well, basically from mom and dad. So so these genetic variants are transmitted from mom and dad to their offspring. So this is a father here. Let's say he's affected with a disease. Let's say he has pulmonary fibrosis. So this is one string of his DNA here that has the green allele, or the green version of the DNA, and that's the good kind. And he also has one version that's a red, which is the bad kind. So that's a variant. The red is a variant that is associated with his disease or pulmonary fibrosis, whereas mom does not have pulmonary fibrosis and does not have any of those damaging variants. So when they have children, they can pass on. So each mom and each dad passes one version of their DNA to each offspring. And so the son here got the green version from dad and the green version from mom, and therefore does not have disease. This daughter here got green version from mom and green version from dad, and therefore does not have disease. But this daughter here got the red version from dad and the green version from mom, therefore she is at higher risk of developing disease or already has disease, and the same for the son. So in these types of disorders, the transmission occurs again from mom and dad, and you get one copy from mom, one copy from dad. So there's about a 50% chance of transmitting this problem variant or this problem mutation to each one of the children. In pulmonary fibrosis, decades ago, we actually recognized that this ran in families. So there were, if you took large families, there'd be multiple members within the family, multiple related members that developed disease. And so this is a fictional pedigree, okay? Keeping in line with HIPAA, this is a fictional pedigree that I made up. But this is a pretty common looking pedigree for patients that we follow in clinic and in our research studies in patients that have what we call familial pulmonary fibrosis, meaning multiple affected members with pulmonary fibrosis within the same family. So if you see, this started off with granddad here. So he was 82 years old when he developed disease. So dark squares and dark circles means they were affected with pulmonary fibrosis, and white circles or white squares were unaffected. So squares are men, circles are women. The line through them means that they have been they're deceased. So this started with granddad here. He had disease. He had a son that developed disease and a daughter that developed disease and another son who did not develop disease. And then there are multiple grandchildren here, the grandson, another grandson that developed disease, and then even a great-granddaughter that developed disease. So pulmonary fibrosis can run in families, and it's generally characterized as having multiple generations that are affected. Okay, so this is what we call autosomal dominant, which is just a genetic term which tells us the transmission or the way that this is transmitted from parent to offspring. Okay, so there's another kind of important tenet here that you can see is that great-granddad developed disease when he was 82 years old. His children developed disease a little bit younger in their 70s. The grandchildren a little bit younger in their 60s. And then the great-granddaughter in her 40s developed disease. So this is something that we also commonly see, which is called anticipation, meaning each subsequent generation may develop more severe disease and earlier onset of disease, which is fairly typical for some of the genetic variants associated with familial pulmonary fibrosis. So in studying patients and families just like this, we've identified 11 or 12 different genes that have been linked to development of familial pulmonary fibrosis. These are all rare genes, okay? So they fall into two general categories. You have the surfactant gene. So surfactant is a protein that's made only in the lungs. And so when it's abnormal, it can develop lung disease. And so there's 5 genes here. There's been a couple other genes that are associated with childhood onset pulmonary disease that are not listed. So these are the adult onset ones. The other group is called the telomere genes. So there are 7 genes that have been associated with familial pulmonary fibrosis that affect the telomere. These genes not only predispose to developing pulmonary fibrosis, but they also cause what we call abnormally short telomere lengths. Okay, so the length of the telomere is short. So what in the world is a telomere? Well, I showed you earlier that these are chromosomes, right? So this is the X-looking chromosome from the nucleus of the cells. Okay, so these chromosomes are the tightly packed DNA, and on the tips of each chromosome is what we call the telomere. These are protective caps located at the end of each chromosome. The telomeres are made up of letters, just like the other DNA, but they're 6 letters that are repeated over and over and over again. So a normal telomere may be several thousand repeats of these 6 letters in a row. This is a picture of an actual human chromosome. So there's lots of chromosomes in here. And the little green dots located at the end of these chromosomes, those are what the telomeres look like. So that's an actual kind of chromosome, or karyotype is what we call that, of a patient. So telomere length is quite literally just the length of those repeat letters at the end of the chromosome. Telomeres normally shorten with age. This is a normal phenomenon. So in a person that is 40 years old may have a telomere length that is, roughly this long. By age 60, it's a little bit shorter. By age 80, it's even shorter. And by 100, assuming they live to 100, it's even shorter. Okay, these telomeres can have an accelerated loss of their telomere length that lead to abnormally short telomeres. So if you take a similar person who at age 40 had a telomere length that was, quote unquote, normal for their age, but yet by age 50, the telomere is short as someone that should be 60 years old. And then by 60, they're shorter, or as short as someone that's 80. Then by 70, they look like a 100-year-old person. So telomeres can have an accelerated loss of their length, and that has been associated with problems and has been associated with pulmonary fibrosis. So when we put these into context, let's look at familial pulmonary fibrosis. So this is pulmonary fibrosis, again, that runs in families. So if you take all patients with pulmonary fibrosis in the world or in the country, about 20 to 30% of them will have other affected family members. So we think familial pulmonary fibrosis makes up the minority of people that have pulmonary fibrosis. So most patients have sporadic disease, meaning they have no other relative with pulmonary fibrosis. They just developed it by themselves. But if you look at the patients with familial pulmonary fibrosis, only about 2% of them will have one of those surfactant gene mutations or variants. About 25% of them will have one of those variants in the telomere-related genes that I listed on the table. But 50% of them will actually have short telomere length. Okay, so that means even without one of those telomere-related variants, that you can still have short telomere length. And about 50% of patients with familial pulmonary fibrosis don't have either of these gene variants, and they have normal or not short telomere length. So we still don't quite know their genetic cause of their familial pulmonary fibrosis. When you look at sporadic pulmonary fibrosis, you see a similar trend. So again, sporadic means there's no other relative in the family that has pulmonary fibrosis. In these patients, again, about 1% will have a surfactant gene mutation or variant. 10% will have one of these variants in a telomere-related gene, and about 40% of them will have short telomere length or abnormally short telomere length. So you still see similar trends even in patients who have, a quote unquote non-genetic form of pulmonary fibrosis. So we think that genetics really, influences not only familial disease, but also plays a role in sporadic disease too. Excuse me. So why do we care about this? So when I'm seeing a patient in clinic, how could I potentially use genetics to help care for my patients? Well, I think it helps in a couple of different ways. So if you look at susceptibility, so who's going to develop disease? Once they develop disease, can genetics help us figure out their prognosis or what they're going to behave like over the next couple of years? And can it help us inform kind of our therapy? When we talk about common variants, the answer to all those questions is a huge maybe. We really don't know. Like I said before, common variants really have a fairly small effect size. And so we're still trying to figure out how these play into the whole architecture of genetics in pulmonary fibrosis. But when we look at the rare variants in short telomere length, we think that these genetic markers may actually help us in the clinic to identify or answer some of these specific questions. So going back to our pedigree that I showed before, if we start thinking about susceptibility, to me that means someone that does not have pulmonary fibrosis, what is their risk of developing pulmonary fibrosis in their lifetime? So if we look at this family here, again, we have great-granddad here that had disease, we have offspring with disease, we have grandchildren with disease, and we have a great-grandchild with disease. So if we just look at this nuclear family here, okay, if this person comes to my clinic and says, my dad had disease, my sister has disease, what's my chances of getting disease? My answer to them is, well, I don't know. But I may be able to find out if we do a little bit of testing. So let's assume that we did genetic testing on some of the relatives that are still alive, okay, and we find that dad had a variant or a mutation in a gene that is associated with pulmonary fibrosis, and its sister has the same mutation and has disease. Let's say uncle does not have disease and does not have that same mutation, but the cousin does have the mutation and has disease. So we call this segregation, meaning the disease segregates or occurs in the same people that have the variant occurs in the people with disease, but does not occur in the people without disease. So again, segregation. So then if I test this patient for that exact same variant and I find that they are positive for the variant, then their risk of developing disease is higher, or their susceptibility risk is high. Whereas if they're negative, their risk of developing disease is lower. How low? Well, it's probably not zero, because we do know that there are other non-genetic causes of pulmonary fibrosis, right? And so their risk of developing disease may be higher than someone just walking on the street, but yet not as high as someone that has one of these variants. So it does help us in figuring out who's at risk of getting disease. But it doesn't really help us figure out what disease they're going to develop. So remember, within the realm of pulmonary fibrosis, there's 100 different types of pulmonary fibrosis. So idiopathic pulmonary fibrosis, or IPF, is the most common, but there's several other types. So this is the actual CT scans, and it's not really showing up all that well, of two sisters that have had genetic testing. So they both have the exact same variant or mutation in a gene called TERC, T-E-R-C. So they have the exact same genetic mutation, yet the disease they develop is actually quite different. So this CT scan shows scarring kind of in the top part of the lungs here on both sides, whereas this sister has developed pulmonary fibrosis that's more in the bottom and in the back part of the lung. So these are different subtypes of pulmonary fibrosis, but they have the exact same mutation. So the mutation or the variant can inform whether they are going to develop disease, but it still doesn't tell us what disease they're going to develop, okay? So again, genetic variants do not inform the subtype of pulmonary fibrosis. We still have to do our due diligence to try to figure out what subtype they have so that we can get some information regarding therapies and disease behavior over time, because the subtype still informs that aspect of pulmonary fibrosis care. So I'm going to get into a little bit of data here, but I'll also give kind of the broad strokes overview of what the data mean. But this is a study that we did a couple of years ago where we took patients from families that had one of these mutations in a telomere-related gene, and these are the genes we looked at, so TERT, TERK, RTEL1, and PARM. The genes themselves are not all that important. What's important is that any patient that had one of these genes actually had a pretty poor survival. So about half of them either died or required a transplant within about 2.5 years, which is really bad. When we looked at their specific diagnoses, we broke them down in IPF versus not IPF, so idiopathic pulmonary fibrosis versus all other types, and it didn't really matter. So the presence of one of these mutations really told us that these patients are going to develop a kind of rapid disease progression and poor outcomes, regardless of what we think their diagnosis is. So we know that the presence of these telomere-related genes leads to bad outcomes. What about short telomere length? So we know these telomere-related rare variants can cause shortened telomere length. And so we looked at just telomere length. So we looked at patients that had idiopathic pulmonary fibrosis. This is sporadic idiopathic pulmonary fibrosis, so not familial. And patients with another type of pulmonary fibrosis called chronic hypersensitivity pneumonitis. So again, sporadic disease, not familial disease. And in this study, we looked at telomere length and broke it up into quartiles. So we had the shortest, then kind of short, then kind of long, and then the longest. And the patients in the red line here with the shortest telomere length had the worst outcomes. Same way in hypersensitivity pneumonitis, patients with the shortest telomere length had the worst outcomes. So short telomere length also leads to bad outcomes in patients with multiple different types of pulmonary fibrosis. Not only does it lead to kind of worse survival or faster need for transplant, but it also causes faster decline in their lung function. So this is kind of a busy figure here, but this is looking at the pulmonary function test change per year. Okay, so when you come to the doctor, we are having you do PFTs almost every time, and it's so that we can kind of graph out your trajectory and how things are changing. And our goal is to keep everything stable. But when people are progressing, we have to make adjustments. So looking at patients who have idiopathic pulmonary fibrosis and then two other types of pulmonary fibrosis, it's called IPAF and then connective tissue disease, we see that those that had short telomere length had faster decline in their lung function, regardless of their ILD type, okay, or their pulmonary fibrosis type. So again, short telomere length not only leads to kind of worse outcomes and worse survival, but it also leads to faster progression. So these patients really do represent kind of an extreme form of pulmonary fibrosis. So the big question is why? I mean, what's causing this? And the short answer is we still don't know, but we do have some ideas. And I think that some of this kind of goes back to the way that these forms of pulmonary fibrosis are treated. So if you look at types of pulmonary fibrosis, so you have idiopathic pulmonary fibrosis or IPF. Remember, this is the most common form of pulmonary fibrosis and is the most progressive form or aggressive form. So if you take those patients with idiopathic pulmonary fibrosis versus patients that have any other type of pulmonary fibrosis, so just non-IPF. In general, we treat patients now with that have IPF with antifibrotics. These are Esbriet and Ofev. These were approved in 2014, and so we've been using them now for for 5 or 6 years. And so we know that these medications are beneficial for patients who have idiopathic pulmonary fibrosis. For most other non-IPF forms of pulmonary fibrosis, we treat with medications called immunosuppressants. So these are medicines that decrease inflammation and decreases the immune system. And for the most part, we think that they're beneficial. Although there's not a lot of studies on these, but anecdotally and small studies show that they are beneficial. The problem is that in patients who have idiopathic pulmonary fibrosis who were treated with immunosuppression leads to bad outcomes. Okay, so these are harmful, or we think they are harmful in patients with idiopathic pulmonary fibrosis. And the reason we think that is based on a study that was published in the New England Journal of Medicine back in 2012 that absolutely revolutionized the way that we not only treat pulmonary fibrosis, but the way that we approach diagnosis of pulmonary fibrosis. So this study looked at patients with idiopathic pulmonary fibrosis and treated them either with a combination of prednisone, azathioprine, and N-acetylcysteine. So we call that triple therapy, which was the standard of care back in the early 2000s. The problem is, in this study, it actually had to be stopped early. So if you look at the patients who were treated with the triple therapy arm, with the immunosuppressant arm, compared to those that were on placebo or sugar pill, there were 8 deaths compared to 1 death and 23 hospitalizations compared to 7 hospitalizations. So this study was stopped early. So this is why when we're doing these randomized controlled trials, we often will do what we call an interim analysis to make sure that, number one, our therapy is not causing harm, or number two, our therapy is very beneficial. So then we would stop the study early and either say we can't do this anymore, or we need to do this more, depending on what we see. So this is an example of stopping the study early because it was causing problems. So one of the things about what really got us thinking is this study kind of revolutionized the way that we approach treatment of pulmonary fibrosis. And we wondered, is it the immunosuppression that's causing a problem, or is there something else going on here that makes these patients at higher risk when they're put on these medications? So again, idiopathic pulmonary fibrosis put on these immunosuppressant medications led to bad outcomes. An interesting phenomenon occurs in patients who have short telomere length, is they actually have kind of this relative immunodeficiency. So it's oftentimes subtle, but their immune system really doesn't work normally. So we wondered, if someone doesn't have a normal immune system and then you put them on medications that further suppresses that immune system, is that what's causing the problem? So we actually got the DNA from that study, and measured telomere lengths on that study. And we showed in patients that were on the treatment arm, the immunosuppression arm, that had short telomere lengths, they had the majority of deaths and hospitalizations compared to those that had longer telomere lengths. Further, if you look at just the patients with short telomere length, this is another graph that shows the survival, those patients that were put on drugs, so this blue dash line here, actually had worse outcomes compared to those that were just put on sugar pill and had short telomere lengths. And further, in patients that had the longer telomere lengths, it didn't really matter whether they were on the therapy arm or the sugar pill arm, they kind of did the same. So we wonder, is the short telomere length really interacting with this immunosuppressive therapy, and that is what's leading to poor outcomes? Now, the study has not been replicated. I mean, we replicated it in a couple of different cohorts in this paper, but we don't treat idiopathic pulmonary fibrosis with immunosuppressant medications anymore because of this study. Okay, so the question still remains whether this is a true, interaction between someone's genetics and the medications that we put them on, but at least it's kind of thought-provoking and needs more study. The good news is that in patients with idiopathic pulmonary fibrosis, we don't treat with immunosuppressants anymore. We treat them with antifibrotics like pirfenidone or Esbriet and nintedanib or Ofev. And so this was a study that came out later, and it shows patients here in red that have short telomere length that are put on sugar pill, they have this decline in their lung function that's pretty steep, right? That's a pretty drastic decline. But in the red dash line here, the patients that were put on Esbriet slowed down their progression, even though they had short telomere lengths. So Esbriet or pirfenidone really does seem to slow the rate of progression, even in patients with shorter telomere lengths. And so this is quite helpful and is very encouraging, because patients that we know have one of these mutations, we have a medication that we're pretty certain will slow down their disease progression. We also think that Ofev or nintedanib does the same thing, although we don't have as good a data to support that, but anecdotally, it does appear to also be effective. So going back to the table that I said before, or that I showed before, knowing whether someone has one of these rare variants or these mutations or short telomere length not only helps with, finding out if someone is susceptible, even if they don't have disease, but yet are susceptible to get disease, helps a little bit with prognosis and with their disease course, and might help when we're trying to devise the optimal therapeutic strategy. So genetic testing. So it is available. but we don't do it all that much in clinical practice. There's a lot of patients who are just seen by even physicians in our group or at large academic medical centers are really not given the option of doing genetic testing. And the reason for that is because we still have a ton of unanswered questions. So first of all, who should we test? Should we test everyone, or should we only test certain people? How should we test them? So there's multiple ways to do genetic testing, and we still don't exactly know the best strategy for testing. And then what are the risks and what are the benefits of testing? So let's go through a couple of these kind of in my last few slides here, and I'll kind of give you some insight into why your doctor probably has not offered you genetic testing, even why I have not offered some of you genetic testing. So last year, I was part of a group that kind of was coming up with a document to help clinicians and patients understand genetic testing in pulmonary fibrosis. We did that through the Pulmonary Fibrosis Foundation, and there's a link at the bottom of the page here that kind of will give gives a summary of our document that's written for patients. There's also a healthcare provider document that's on their website. So this is published and is available for public use. So what we came up with as a group is that patients who have a family history of pulmonary fibrosis, so if mom, dad, brother, sister, aunt, uncles, cousins, somebody else in the family also has pulmonary fibrosis, then we should be offering genetic testing, or at least discussing genetic testing, okay? If we do the genetic testing and we find a genetic variant that is associated with pulmonary fibrosis or causes pulmonary fibrosis, like one of those telomere-related genes or those surfactant-related genes, then we could potentially offer genetic testing to unaffected relatives, again, to try to identify the susceptibility or the risk of an unaffected relative on developing disease. On the flip side, as a group, we decided that patients who do not have a family history of pulmonary fibrosis, so these would be people with sporadic pulmonary fibrosis, that we still don't know enough about who to test and how to test and when to test. So we kind of came up with our opinion that we should not offer genetic testing for patients without a family history just yet. Now, again, there's still a lot of research going into the impact of genetic testing on patients with familial disease and without familial disease. And so this is subject to change over the next few years, but right now this is the only document that's actually available to guide clinicians on who should be testing. So if we decide to test someone, how do we actually test them? Well, we can do it two ways. We can do a blood test, or we can do a saliva test. So it's kind of like the 23andMe, right? You can do the swab inside the cheek and then send it in, and they'll do testing. But once you get the sample, there's actually three types of testing that can be done. You can do whole exome or whole genome sequencing. That means that you are actually looking for the letters, the A, T, C, and G for all or almost all of the DNA. So, the 20,000 genes, you're looking at all of them. On the other hand, you can do what we call panel testing, where you're only doing sequencing or looking for the letters of the DNA in the genes that have been associated with pulmonary fibrosis. So some of these panels will have, 15 or 20 genes. Some of them will have 10 genes. It just depends on the company. But this is a much smaller sequencing test, and therefore the cost is less. The cost for whole exome or whole genome can be quite expensive, on the order of a couple $1,000s. The other test we can do is we can actually just measure the telomere length. So we can quantify how long a person's telomeres are. And so these are the three types of tests. But I'll tell you that the genetic testing results, they often don't give us a positive or a negative answer. So if you go to the lab to get your blood drawn to check your kidney function, we get a number back for a kidney function, and we can tell whether that number is high or low, and it gives us an idea of the function of the kidneys. That is not the way this works for genetic testing. We often don't get a black or a white answer. The answer is gray, and then we have to interpret the results based on prior genetic studies, prior studies for our individual patient and our family members. And so oftentimes, even if we did genetic sequencing or offer genetic sequencing, we still may not get an answer that is satisfactory to either your doctor or to you. And so we still have to do a lot of work on trying to figure out what's the best way to interpret these tests once we do them. What are the risks and the benefits? Well, there can be lots of benefits, right? So you can, if you know that you have a mutation or you don't have a mutation, it may help with family planning. Maybe not for you, but maybe for your children or your grandchildren, to try to figure out whether they carry this variant or not. And so it can help with family planning. It can also help, like I said earlier, with determine the risk or the susceptibility for family members that are unaffected at the time. I put question marks here. It may inform prognosis and it may inform treatment strategy based on the data that I presented earlier, but some of that stuff is still in flux and we're still learning more about it. So the benefits really, I think the biggest benefits really are on family planning and susceptibility. What are the risks? Well, these tests are costly. Unfortunately, for most of these tests, insurances are not covering fully. And so there's a financial burden, not only of the test itself, but then for follow-up. So just imagine if someone that does not have disease had genetic testing and was found to be positive for one of these mutations, then those patients are going to be followed potentially for years. If it's a 40-year-old patient who may not develop disease until they're 70, then there may be 30 years worth of follow-up that can lead to a significant financial burden. On top of that, there can be some psychological harm. If you think about it, if you know that you have a predisposition for a potentially terrible disease that may or may not occur, whether just because you have the variant doesn't mean you're going to get disease. And so that can lead to a lot of uncertainty and a lot of psychological distress that could last for years and years. The last risk is more of a logistics one of insurability. So there was a law passed in the early 2000s called the GINA law, GINA, that prevents health insurance companies from discriminating based on genetic testing results. But that does not extend to disability insurance or life insurance most of the time. And so patients who in their 20s and 30s and 40s who find out that they are carrying one of these mutations, it may be difficult for them to get life insurance or disability insurance, or their premiums may be really high. So, those are actually significant risk. So what I tell patients and families when I'm counseling on whether we should do the genetic testing or not, I tell them this is a highly personal decision, that really needs to be discussed not only with the patient themselves, but also with their family members. Is this something that they want to know? Because once we do the testing, again, even if we did the testing, we may not get a definitive answer. And if we get a definitive answer, is that something that they want? Okay, so there's a lot of things that a lot of thought that needs to go into, whether someone should be tested and then what we're going to do with those results. So in summary, we covered a lot of stuff today, but the big picture here is that there are genetic variations or variants that are associated with pulmonary fibrosis. And they not only inform development of disease, but they may inform disease course. These rare genetic variants are actually fairly common in families with familial pulmonary fibrosis. Like I said earlier, we find one of these variants in about 25%, which is a pretty big chunk of families with familial pulmonary fibrosis. These variants may inform prognosis and they may inform treatment, but additional studies really are needed to know how we can start using this clinically and how we can use this information to make decisions for an individual patient in clinic. We're not quite there yet. And then lastly, genetic testing really should be offered to patients that have a family history of pulmonary fibrosis. Just because it's offered doesn't mean that it has to be done. But again, this should be discussed, okay? And so that's, something that I feel fairly strongly about in all the patients that I have that have familial disease or, other family members. At some point during our conversations, we will talk about genetic testing and whether it should be done. Remember, something I also tell patients that I didn't put in the slides here is that your DNA is not changing, which means that your testing does not have to be done immediately, that you have time to think about it and to discuss and to really contemplate whether you want to know this information or not, because again, it's not changing. Okay, we could test you today, we could test you 5 years from now, and your DNA is going to be about the same. Okay. So with that, I'll wrap up, but I just want to give a shameless plug here to our interstitial lung disease program at UT Southwestern, which I'm just happy to be a part of. And we have several different providers in our clinic who primarily specialize in patients with pulmonary fibrosis. If any of you have been in our clinic, you've probably met Tion. She's our nurse practitioner who quite literally drives our program. Without her, we would be absolutely lost. And so most of what we do really is all thanks to her. Our program is, I'm biased, but I want to say that we have a good program. We're part of the Pulmonary Fibrosis Care Center Network, which is a kind of a growing network of clinics around the country that kind of signify, a level of expertise in managing patients with various types of pulmonary fibrosis. And then this last year, we were actually ranked nationally by the U.S. News and World Report as one of the nation's best pulmonology departments. So there's a link at the bottom of this page here that it goes to our clinic's website. And so if you're interested, you can take a look there. There's also some patient information and links to other websites, including the Pulmonary Fibrosis Foundation website, I think, also that has fantastic information for patients and families. So with that, I want to thank you all again for listening, and thank Bill and Shelley and Joe for those kind introductions. And I'd be happy to take any questions.
Dr. Newton, I think like many of us watching, when I saw that, I said to myself, hey, how do I get those suckers lengthened? How do I affect my telomeres to be a little bit longer? Is there any research taking place? Is there any drugs that are in the pipeline? Is there anything we can do to impact that?
Yes. So the short answer is yes. So there is research going into, can you make telomere lengths longer, or can you just slow down this attrition or the loss of telomere lengths? The flip side, although I showed all this data regarding short telomere lengths can predispose to pulmonary fibrosis, long telomere lengths may predispose to certain cancers. And so there's really a fine line in how much, lengthening them may help or hurt, as opposed to slowing down the shortening, which may help or hurt. And so it's not as easy as someone developed pulmonary fibrosis, they have short telomere lengths, what can we do to make them longer? Because we think, although we don't know, kind of the cat's out of the bag at that point, right? They've already developed disease. There's already a process going on. And so lengthening the telomeres themselves may not impact the disease course at all. Having said that, there are studies looking into medication. So there's one that was published a couple of years ago using danazol, which is a hormone, like a testosterone type hormone, that can slow down the loss of telomere length. And it's been looked at more closely in patients who have bone marrow dysfunction or leukemias or aplastic anemia. In pulmonary fibrosis, I'm not sure how much that's actually helpful. And like I said, it could be potentially harmful. So there's research going into it. We don't have an answer yet, but it's intriguing. I agree with you.
Dr. Newton, I have a question. I have always been, as a caregiver, upset about the life expectancy charts, which is the first thing when you get a diagnosis, how long you were going to live, and they're still showing things like 2.5 to 3.5 years if you have IPF. Well, based on that Panther study, it looked like doctors were killing patients early, and that should be excluded from the calculation of life expectancy. And only, data from 2012 going forward. So have you seen anything like that? And they are still showing these short life expectancies, which we know don't apply anymore.
So there's not been really large epidemiologic studies, meaning taking, thousands of patients and looking at life expectancy now, given that we're not treating patients with medications that are potentially harmful. So the short, the 3 to 5 year life expectancy was initially kind of came out of data from the 90s and the early 2000s, when we probably were making people worse or potentially making them worse with the way that we were treating them. The antifibrotics probably do make people live longer. I mean, there's actually pretty good data now to say that they do. They've only been on the market for 6 years now. And so it's still a little bit early to know their actual impact in large cohorts of patients on the life expectancy. And so that may not be something that we know for another 5 or 10 years, where we have, long longitudinal data where we can look at that specific answer. But given that these medications do slow down progression, and they do probably make people live longer, the 3 to 5 year mark may not be correct. On the flip side of that, it still may be fairly correct. The reason is, with pulmonary fibrosis, there's a phenomenon called acute exacerbations, where patients, for no good reason, can just have a steep decline in their lung function and their oxygen needs and feel short of breath. And those can occur almost randomly or seemingly randomly. And so that still is going to kind of push the life expectancy toward the shorter end, because they occur in some studies 5% of patients per year. And so the antifibrotics do decrease the risk of acute exacerbation, but they don't make it zero. And so there's still going to be some patients who, for whatever reason, whether it's genetics or whether it's an environment or whether it's infection or heart disease or something, that are just not going to do well. They're going to continue to progress quite rapidly. And then you're going to have some patients who, on these medications, will stabilize for years and years. And so where that average kind of ends up being, we don't quite know. And for an individual patient, is what I tell people when I have my conversation, that, hey, look, I think you have idiopathic pulmonary fibrosis. This is the data that I can give you. But I tell them, I follow this up with, I don't know what you're going to be like. Every patient is different. And so I have some patients who have had this diagnosis for years and years and years, and they're still stable and fine. And I have some patients who I give this diagnosis, they're already severely impaired, and over the next 6 months to a year, they get even worse. And so each individual patient really does have their own specific trajectory. And so as physicians and as patients and as caregivers, it is unsettling to know I can't predict the future. And so we just have to be mindful that we're using medications that we should be using. We're avoiding medications we should be avoiding. And we're following things closely so that when we start seeing changes, that we can make adjustments. And that's kind of what I tell patients, is every person is their own individual study, and no two people are alike.
Dr. Newton, I think I probably speak for everybody here. We're always looking for the silver bullet. What do we do to stop it, cure it, fix it? From your perspective, without naming names per se, can you give us some, I'm going to call it hope and insight, what may be around the corner for us?
Yeah, I think there's tremendous hope. This is a fantastic time in the pulmonary fibrosis world. You couldn't say that back in the 90s or 2000s, right? There are drug companies that are really interested in pulmonary fibrosis. And because of that, there are dozens of compounds that are being studied in pulmonary fibrosis, not just in IPF, which is nice. Okay, IPF is common. It is the worst kind, but there's other forms of pulmonary fibrosis that can be just as progressive. And so there's a tremendous interest in trying to find new therapies that help slow the progression of disease and potentially cure the disease in patients. And so there are several of these compounds that are in phase 3 studies, so kind of the last hurdle before they get approved, that look promising in earlier studies. And so I'm hopeful over the next few years, we have more in our armamentarium to treat patients with, not just nintedanib and not just pirfenidone, but other medications, either in combination with those meds or by themselves. So I think over the next few years are going to be really interesting to know, what we can do.
I have a question. Doctor, thank you very much for being with us. I don't know if you can answer this question in this form or not, but let me give you just a little history. I was diagnosed with IPF 5 years ago. I've been taking OFEV for about 4 years. Currently, in addition to my OFEV, I'm taking NAC and a low-dose prednisone. And based on what you said, I'm wondering if I need to revisit that with my doctor.
Yeah, I think you should potentially revisit with your doctor. There are some circumstances where we may use those other medications, and it would be appropriate for those. But without knowing a little bit more, it's hard for me to say whether that's right or wrong. NAC or N-acetylcysteine, some people use it to help with cough because it seems to help with cough. And so that may be completely appropriate. Prednisone can be used for lots of different things. And so again, the study that I showed, the Panther study, really was the combination of those three medications, the NAC, the prednisone, and the other medication called azathioprine that was associated with harm. There was a separate study that just looked at NAC, and NAC really didn't help and it didn't hurt. So we still don't quite know, why that study showed harm. We have some suspicions, but we don't quite know. And so, some people still need those other medications for other indications and for other reasons. And for that, it may be completely appropriate.
Dr. Newton, I have a question for you. I have familial PF in my family. I have lost 5 family members. And I'm wondering if you think that the estimate of familial PF, which has gone up over years significantly. When my brother was diagnosed way back in 1995, they told us it was all idiopathic. But I wonder if you just saw the new study by Dr. Alberto in the ATS Annals, where they looked at siblings of sporadic patients, not just familial patients, and saw up to 33% had signs of ILD. And I don't know if that's a function partly of some self-selection going on, or whether it's some cases where people don't know their family histories. For example, after a couple of years after my brother died, I found a cousin in England just through genealogy. I wasn't looking for IPF, whose sister had IPF. So she was considered sporadic. What they didn't realize, obviously, was that they had cousins here, but they didn't realize that their great uncle had it because they hadn't gone through the records. So most people don't know their family history, obviously, overseas. But I'm just wondering if you have any sense about how that might affect testing or estimates of prevalence for familial PF.
Yeah, I think so. I've seen the study. I think a lot of studies like that, and ones that we've tried to do too, there's a huge selection bias, right? It's not like we're able to ask all patients with pulmonary fibrosis to get a true, prevalence of how many people have a family history. And a lot of that's for the reasons that you said. People don't necessarily know the medical history of all of their family members. And it may be that there's a distant cousin that has disease, and you just wouldn't know it. Oftentimes too, remember that people can develop disease at different time points in their life. And so when a patient comes in and we go through a very detailed family history, they may not know that someone is also going through a similar workup at the same time, or 2 or 3 years from that time, their brother may then develop disease. And so this is studying families and family units is sometimes difficult to do and is subject to bias. There is, like I showed, even in patients with sporadic disease, there's still some of these genetic abnormalities that are present. And so if they're present in a patient with disease, they may be present in other family members that either have mild disease and it's not symptomatic yet, or will develop disease in the future. So we're still learning about the overall prevalence of disease, and it probably is a little bit more common than what we think.
Okay.
Dr. Newton, this I think we'll touch on what Linda's asking about too. I'm part of a study being done by 23andMe on IPF specifically, and they have 2,000 cohorts. So it's a fairly large base of cohorts and testing. It's a saliva test. Knowing 23andMe and Ancestry and what they do, I'm not sure exact the verbiage for it, but I don't think it's too deep and too broad. It's pretty narrow, but it's being done. Those kinds of tests that are being done in that way, how do you look at them as far as credibility? Because I've had personally mixed results with 23andMe and Ancestry where I've had genetic testing because of genealogy. And I went to 23andMe 3 times and they could never get my DNA for a match. So Patty's convinced I'm an alien, but that's okay. But how do you look at those kinds of tests from scientific validity and what you're doing and your peers are doing as far as research?
So the commercial testing, for genealogy purposes, they don't necessarily have to do this exact same stringent quality control that, say, a lab that, if we were doing genetic testing on you, Bill, and sending it off to a lab to get an answer, they don't have to do the exact same quality control as those. And so there might be mix up with samples or like you said, not sequencing to the right depth to actually determine whether there's something there or not there. And so sometimes those things may not be as accurate. However, if one of these variants is identified, then it's probably there. I think these types of companies, the 23andMe and the Ancestry.com, I think is another one, they're a tremendous resource. If you think of how many people have submitted samples, it could be a potentially representative population of the community in general. And so starting to use those resources to try to find genetic links in a, quote unquote, rare disease like pulmonary fibrosis, I think is fascinating. And it'd be really interesting to see, what they find in those large cohorts. In the pulmonary fibrosis world, the Pulmonary Fibrosis Foundation has a biorepository where they've, collected around 2,000 patients that have disease too. And then there's other cohorts of patients, of pulmonary fibrosis cohorts that are also, nearing a couple of thousand. And so there, within the research community, a lot of people are really starting to collaborate. So instead of just working in our little silos, working with investigators and researchers across the country and across the world to really start answering some of these questions. And that's something that we're really keen on doing. And I think kind of with, you combine, commercial research like with 23andMe with academic type research, I think we'll start getting a little bit more better picture of what's actually going on in the prevalence of some of these genetic markers.
I have another question that's kind of COVID related, but we understand that some of the folks who get COVID, not all of them, will have lung scarring, which is pulmonary fibrosis that they might have to deal with the rest of their lives. But I'm wondering if the people more susceptible to getting the lung scarring after COVID might have that gene variant.
Yeah, it's really interesting and really topical question. I don't know, maybe. So we are starting to see, some people that have had COVID and had, severe COVID do have scarring in their lungs afterwards. The question that we still don't know is, does that scar get worse over time? So something that kind of differentiates pulmonary fibrosis, specifically idiopathic pulmonary fibrosis, is that once the scar is there, it kind of feeds on itself and it progresses. And so there's more scar that forms and more scar and more scar. What we don't quite know in patients with COVID is whether once that scar is there, does it start feeding on itself and lead to a progressive disorder? We're not sure yet. I mean, this is still new to us also. In other forms of similar types of fibrosis, so people that have, a really bad pneumonia that end up on a ventilator, oftentimes when they get pulmonary fibrosis afterwards, it's not progressive, meaning it's there, doesn't go away. Their lung function may be impaired, but if you check them 5 years from now, their scarring is roughly the same and hasn't really progressed. So we don't quite know. My suspicion is that some of the people that do progress after COVID, they may have some predisposition for having disease either way. And so there may be a genetic link. We don't know yet. There's a lot of interest in what happens to patients after having COVID. And so it's probably not an answer we're going to have for another several years, but I think you may be right that there may be genetic predisposition for getting it and then getting bad lung disease afterwards.
Yes, doctor, thank you so much for your fantastic talk. It clarified a lot of things for us. And my question is, there are the two antifibrotics, the SBRT and the OFEV. Say you start the patient on OFEV. After a year, you see that he has not become stable. Would you then stop the OFEV and try the SBRT, or the other way around?
So the answer is maybe. It depends on several factors. So, neither one of those medications, so SBRT and OFEV, are without side effects. They both cause some side effects, and there are some cases where we may, want to avoid one medication and use another one. In general, patients who are on one of the medications who are not responding or are getting worse, you can switch to the other one. In some patients, they'll start responding and stabilize, and some patients won't. The question is, why would they not respond? Is there something else going on that we don't quite understand that means that they're not going to respond to either one of these medications, so we don't know. Another school of thought, and there's data to back this up, is that some patients who initially, they get put on medication and they're declining, that some of them will stabilize. So even after 6 months or a year of declining, that they'll kind of start responding or appear to be responding to the medication even without changing. And so it really takes you have to be kind of mindful and thoughtful on whether you're going to switch medications. And if you're not going to switch medications, then you may have to follow up a little bit closer to make sure that you are going to start responding at some point.
Doctor, from the commercial side almost, is your work funded under a directed grant, or are you budgeted under TSW? And what about the adequacy of your funding?
So my research is funded by the National Institutes of Health, the NIH, and some by UT Southwestern. And so my division and my department and my medical school, and then the government actually supports my research.
And that seems adequate to you then?
We're always looking for more funding.
We as a team of lawyers did help fund Dr. Newton's predecessor, Christine Garcia, the Garcia Lab, when it was at UT Southwestern. We did make a donation and raise money for that purpose from one of our members. And we're looking at doing that in the future, not just with research, but also for transplants.
Dr. Newton, I have a quick question. I know in-person appointments are out right now with COVID. Is that probably going to continue until this is completely over?
Maybe. So right now we are seeing most of our patients through telehealth visits. We can still get testing. So if we're seeing a patient, we can still get pulmonary function tests and still get labs and still get CT scans. It just takes a little bit more planning and making appointments than what it used to take. We can see some patients in clinic. So there's a few people that I, for whatever reason, just want to see them face to face. And so we can make arrangements for that. I don't know when we're going to go back to seeing, primarily in-person visits. We may not go back. We may keep doing at least a version of telehealth and in-person, but we're still seeing patients, and we're still able to get whatever testing we need to get testing for.
Thank you.
Dr. Newton, do you see any scope for targeted drug development using the knowledge you may have gained from the DNA study of particular patients?
I couldn't hear part of the question. You said targeted treatments based on the DNA?
Yes.
Yes. So there are studies that are ongoing right now or starting up right now looking at using someone's genetic kind of architecture to come up with an optimal treatment strategy. So there are studies that are going on that are looking at that. I think that's actually a quite interesting kind of aspect to research that I think probably has legs and may impact the way that we're approaching treatment decisions in the future. We're not there yet. This is not something that, I showed data about, testing someone's telomere length and then picking a drug just based on that. We have to kind of take in, a lot of other variables that go into those types of treatment decisions. But I think hopefully, maybe naively, hoping that something like that would be available in the future. That's something that's kind of akin to the precision medicine, where you pick a treatment based on an individual's genetic and molecular makeup, as opposed to just common findings between groups of patients. You actually make decisions based on an individual patient, and so we're not there yet. Hopefully, we'll start making steps toward doing that over the upcoming years.
Thank you.
Such an important topic and such a quiet group. Almost you're whispering. Should I call on some people? No. Okay. Dr. Newton, I have to thank you. Giving your Saturday to us is so generous of you, generous and important. And what a great topic. And you made it so simple, even I understood it. Thank you for that. It was really a great presentation, and we all thank you. And this has been, again, Shelley, the job you do on meetings, you just knock it out of the box. You really do. Thank you so much. All right, guys, I think we're over with time. And Dr. Newton, you're getting applause from all of us because you did a great job. Thank you.
Thank you all.
Okay, we'll see you all around the campus.
Bye-bye.
Thank you. Bye.
Bye.